Hello and welcome to this satellite broadcast, Burn Injury, Rural Perspectives. I'm Fiona Wood, I'm Director of the Burn Services of Western Australia. We're coming to you live across Australia through the Rural Health Education Foundation's satellite network. Approximately 1% of the general population in Australia are affected by burn injury each year. That's 200,000 people a year. Of these, 10% will end up in hospital. And of that 10% of those, I should say, will need to go to a burns unit for specialist care. When you look at these statistics, you see that the majority of cases will be managed really by the rural general practitioners or at home. So the importance of getting it right from the first time, right from the point of injury, can't be overestimated. Every intervention influences the scar worn for life. Therefore, everybody who assists in the management of that patient becomes a member of the burn care team. Tonight we're going to have a very practical look at burns, including the importance of initial first aid, clarifying burns classification, a look at management strategies that include the entire multidisciplinary team. There are a number of useful resources available on the Rural Health Education Foundation's website. That's the rhef.com.au. As usual, the broadcast is interactive, so we want your phone calls and faxes whenever you want to ask a question. Don't just shout or mutter, use the phone. So the phone numbers are 1800 817 268. And if you're in the Sydney metropolitan area, you could call 9715 8715. There's also a fax line, and the fax numbers are 1800 633 410, and again, those in the metro area, 9715 8700. Now I'd like to introduce you to our panel for this evening. First of all, we have Eric Lahai. Hello, Eric.
Hi,
and Eric is a paediatric burns surgeon at the Children's Hospital in Westmead. Welcome.
Thank you.
Then we have David Crompton. Hello, David. David is a psychiatrist and area director of the mental health services at Hunter New England Health Service in New South Wales. Michelle McSweeney is an occupational therapist from the burns unit at Concord Hospital. Hi, Michelle.
Hi, Fiona.
And then on my far left, we have David Rosenthal. Hi, David.
Hi, Fiona.
He's a general practitioner from Renmark in South Australia. So welcome all of you. So I would like to think about right from the start, what's the one take-home message that we all have tonight? And I know that my take-home message is prevention is better than cure. So what would our panel like people out there to take home from this evening tonight? Eric?
Well, I agree with you, Fiona. I think 200,000 burn wounds is 200,000 too many. So anything that we can do to decrease or eliminate that has got to be a positive thing. I also think one of the main take-home messages is that what we do in the first 24 hours has an impact on the rest of that patient's life. And if we can get the management right in the first 24 hours, then we can improve their care significantly.
Thank you very much. Absolutely. I think every intervention from the point of injury influences the scar worn for life. And so everybody who actually has an opportunity to impact should really know what they're doing and make the most impact. It's terrific. David?
Fiona, from a psychological perspective, I mean, most people will get on and be okay. However, there are going to be some that will not be. And the important part, I believe, is to have early recognition of problems occurring. And that's not just for the person who's been burnt, but also for maybe family members, other carers, and even we need to remember the emergency workers who also may bring these people into us.
Absolutely. That concept of early, look out for the problems early and start treatment early. Absolutely. Michelle, how about you? What's your take-home message for tonight?
Well, I think we're all saying early, but again, for the multidisciplinary team, early referral, and how that even if you're just a general team member, any team member can make major contributions to the patient in terms of functional recovery from a burn injury.
Thank you very much. Having listened to that, David, as a GP out there on the front line, what do you think you want to take home from tonight?
Well, Fiona, I'll be looking forward to working out where I fit into the grand plan of managing burns. And I think there'll be some very contemporary information tonight, useful information, practical information. And as was said before, there are a lot of burns that can be managed out there, but we need to know that we're up with contemporary standards of management. On the other hand, we have to be ready for the bad one and to know what to do as well.
Absolutely. Thank you very much indeed. Right, what I'd like to go ask now is if we could look at presenting some of the work, some of the information, but don't forget you can always call in with questions. So first of all, I'd like Eric to paint the picture of what we're really referring to when we quote these injury figures. What is it really, what is the extent of the problem and who does burns affect? Thank you, Eric.
Thank you, Fiona. Well, we've talked a lot about the number of patients that are affected in Australia every year, and that breaks down to an incidence of about 1,000 in every 100,000 of population. I think it's always important to try and work out where that fits on an international scale and to see how we compare to other countries. The other countries that do have that sort of information tend to be the wealthier countries, and they also tend to have the lowest incidence of burns. So looking at those figures, we don't actually rate very well against those countries. The lowest incidence figures come from Scandinavia, where they have about 380 per 100,000 of population. The Netherlands has also a reasonably low incidence of 420, but interestingly their incidence has increased significantly over the last 12 years. The US isn't quite sure what their incidence is. They only have mandatory reporting in 21 states, and a lot of those states only report burns greater than 15% body surface area, so they don't have major data. But their rate of 800 per 100,000 is still lower than ours, although some people suggest that that's an underrepresentation. To have a look at what the impacts are and why these differences may occur, I think we need to look at what the risk factors are for burns. And the strongest risk factor that comes out of every study and from every country is low socioeconomic status has a huge negative impact and increases your risk of becoming burnt. That low socioeconomic status may be within the microcosm of a certain population or maybe a population as a whole. It is impossible to get figures from third world countries about the incidences of their burns, but we do know that the death rates that they suffer from their burns are significantly higher, and the body surface area required to cause that death is much lower. So even smaller burns don't survive in the lower socioeconomic countries, which is a very, very sad thing. The other thing we need to note is that our Indigenous population is overrepresented in burn injuries. And in a study that Fiona has done in Western Australia, in burns greater than 50%, found that the Indigenous population had 3 times the rate of the Caucasian population. It's also interesting that that figure comes out from the figures from the United States as well, where they have a rate of 3 to 1 in their where blacks are overrepresented. So whether that is just to do with their socioeconomic status or whether there are other cultural factors is not entirely clear, but it is a very important thing to note and also an important thing to direct prevention programs towards. Another thing that's important in risk factors are alcohol, cigarettes and drug abuse, and they can be factors in both the adult and the paediatric population. Approximately 10% of adult burns have some degree of substance abuse involved with them. The other factors that are important are residential factors. By far the commonest burn injury is a scald injury. We all know that because that's what we all see the most often. The scald injuries come from hot water, and the commonest in the area that I work in children is with tea and coffee. We have had a significant decrease in the number of scalds from taps since legislation was introduced in many states to temper the hot water to 50 degrees, but that's only for new hot water systems, and I think that needs to be expanded across the whole population. Ovens and stoves are still a common cause of nasty burns, and we've had quite a few children who, for instance, used the oven door to stand on to get to something at the back of the stove, and that tips the oven and all of the contents over the child and cause horrendous injuries. Heaters and electrical appliances also cause a significant amount of burns. I've already alluded to who gets burnt. There are 3 peaks in incidence of burns: the 0 to 5 age group, the 65 plus, and then there's another peak in sort of the 25 to 39 age group. These different populations have different types of burns. We've already talked about how scalds are much more common in children. In adults, flame is a much larger proportion, and unfortunately they can cause very severe burns. They also have a significant number of electrical and chemical burns, and a lot of these are work-related, so prevention can be focused in that direction. As the population gets older and starts to get to the 65 plus, or even more clearly in the sort of 80 plus age group, the incidences of the elderly adults mimic the incidences of the children. Scald burns become more common, contact burns start to make a reappearance, and there are a lot of situations where comorbidities are involved, such as stroke or blackouts or hypoglycemic attacks and things like that. So in summary, I hope I've given some idea of sort of where we stand and what the incidence is and what type of people in our population suffer which kind of burns, and then hopefully now focus on thinking about the prevention and management with that as a background.
Thank you very much indeed, Eric. And one of the things that you brought up then was the concept of the increasing numbers of elderly patients we see in our burns units. And that's something that we've certainly noticed back at home, and elderly people do more, being more involved in the community, doing more dangerous things. David, do you see that in your practice as a GP? You see a lot more active elderly people, therefore in risk situations?
Yes, I think we do, and it's not uncommon for them to have burns that are serious enough for them to end up in hospital. I think that education is just so important here. It starts with the children, but it goes on to include the campers at Easter time, who have to be aware that if they have one too many scotches around the fire, they might end up in the fire. And all of those preventive things, particularly in stovetop management, turning the saucepan handles inwards, they're also important. They're simple, but they're important. I'm interested to know what Eric thinks would be the best strategies for GPs and divisions of general practice to use in informing communities. What's the single thing you'd do to reduce the incidence of burns out there?
Well, speaking from my perspective, the thing that I find the most difficult and has such a huge impact on the community are the toddlers. And so trying to get to mothers who are actually having babies or have young children as an education sort of group, I think that would be the most important, because a lot of burns that we see are minor burns but have a huge impact. They're very painful. They may end up scarring. They may end up needing surgery, and all just from tea and coffee. So that if I could focus on one thing, that's what I'd like to eliminate.
I think that's the concept that hot water burns like fire is a very real one, and that's certainly a campaign that we should all be behind. We have our first question, so don't forget, everybody. We're waiting with bated breath here for our questions, but it's pertaining to young children between 0 and 5, and the issues that's around that trauma. And we've heard from Eric, and I'd like to address this question to David in the middle, so we know which David I'm speaking to, that we've heard that these children are vulnerable. We've heard also that children in low socioeconomic situations are more vulnerable. And the question is, are there issues around the personality development with the interruption of or delay or even permanent damage as a result of this trauma? And I'd like to add that to that by putting in the concept that, well, the more vulnerable kids, are they even more vulnerable?
Look, the evidence is that at that younger age, there is a great deal of vulnerability that occurs in this group. And so there is an increased risk that as they get older, there will be an effect on them in terms of their self-esteem, personality development. And so, yes, it is a thing that you have to watch out for and look for in the long term. And again, it's one of the reasons why we need to be involved and be talking and educating families about what to expect and helping them through this period in their life.
Thank you very much. Well, should we, if there's, what I'd like to do is move along to the best way to manage the burn injury and what we can do in terms of prevention. as we've started to discuss that, but we welcome more questions on that with regards to that. But I'd like to now look at the concept of what do we need to do in the first instance? What is the first line management that we need to really have an angle on in order for us to be able to deliver the best possible outcome? And I think what we have to start with understanding is assessment. We have to be able to assess the burn. We have to be able to look at an individual and know what percentage body surface area is involved, how deep is it, and really where of course on the body that is. Hand burn has a greater impact, significantly greater impact than the same percentage body surface area in the middle of the back. So we need those three things: surface area, depth of injury, and body site. And that's the key to our assessment. And then we have to make the decision on whether that patient needs resuscitation and transfer. So in order for an individual to survive with the optimal outcome, those are the three key things that we need to look at in the first instance. But before we go down that, we can actually start to treat at in that first line while we're making those decisions, while we're doing that assessment. And that's with first aid. I'm a great believer in first aid education, and I think it should start in schools and should be continuous and all the way through life. And I think David alluded to that, the fact that we need to keep continually educating. And what do we need to say? It's a very simple message. Stop the burning process, but do so in a safe way. We don't want the individual who is helping to be more injured than the patient themselves. So you've got to bear that in mind. When you've stopped the burning process, it's cooling the wound. And the advice that we give has to be culturally and environmentally appropriate. We say that cooling the wound for 15 to 20 minutes between time 0 and 3 hours, so 3 hours from the point of injury, will impact on that scar that the person wears for life. There is good evidence that it will reduce the depth of injury by 80%. That's very simple. So if you find yourself in a coffee shop and you see a hot coffee go down the chest of a child, and you grab the jug, you cool that wound down whilst you're moving off to and arranging other help, you will influence the scar that individual wears for life, that child, but you'll also influence the impact that has on the health budget. Because we'll move from a situation of a small burn that can be managed conservatively, as opposed to a burn that will require resuscitation and surgical intervention and scar management that we'll come back to with Michelle. So that's the real crux of first aid, is minimising the impact of that injury. When we start to go into more depth, of course, if there's a chemical involved, you've got to think about yourself even more. If there's electricity involved, you've got to make sure you don't get involved and make sure you don't sort of include yourself in the circuit. So safety is a real priority, but minimisation of the injury is the priority for that individual patient. So then we've got to think about who do we actually refer on? Who do we, after we've made that initial assessment that can be made very quickly, what kind of framework do we understand that we can contain that, can treat that patient locally or move on? Now we have the ANZBA criteria for referral, and that really is burns greater than 10% body surface area in an adult or 5 in a child. Any full thickness injury of significance, for example 5% body surface area, will require surgical intervention. So you've really got to consider, do we refer early to give that patient the best quality outcome so that they can have the benefit of the multidisciplinary team and scar management from as early as possible. Then we've got to think about the body site. As I've said, that's really important. We have sites of special areas: the perineum, the hands, the feet, the face. All these areas around major joints and burns that involve a circumferential limb are all really important, because they are the ones that really can influence the quality of that survival, the functional outcome, as well as the cosmetic outcome, which of course has a profound impact on the holistic outcome when we look at the psychological impact on that patient. We've also got to think about burns with inhalation injury and burns with involving electricity or chemical injury. So when we think about what we can achieve in our environment, we have to think of what our skill level is. What is it that we can do? What equipment have we got available? And what are our patients' needs? And bring that triangle together. Bring the triangle together to understand what it is that we can do and what it is that that patient needs. So we've assessed the patient, we know the body surface area, we know the depth and the body sites involved, we know whether there's been such things as electricity or chemicals involved. There's a smoke inhalation component if it's been in an enclosed space. Do we know this patient has other problems? Are there comorbidities that will make this complicated for this individual? Have they had a past history of cardiac problems, for example? Are they diabetic, which will influence their healing? We can gather all that information, then we ask the very next most important question is, will that burn heal in 10 days? Now, if that burn injury will heal in 10 days, then we're quite comfortable following a conservative path. And I think we'll come back to what dressings we use in a moment. If that burn will not heal in 10 days on our assessment, then we're considering surgical intervention to give us a situation of scar minimisation. Therefore, the assessment of depth becomes crucial. And that's a very interesting situation, because it may be that you assess the depth within a few hours, and then you come back the day later and you think, I've got that wrong. Well, you didn't. The wound evolved, the wound changed, the condition of the patient changed, and the wound may well now be full thickness and require a different level of care. But the key is to repeated assessment, is looking back, always making sure that you reassess, because you know that this burn wound evolves over the period of time. And what you see in the first few hours may not be what you see a couple of days down the track. And so you may have to communicate repeatedly with the burns teams over a period of time until the final decisions are made. The next issue, I think, is if the burn will heal in 10 days, then, as I said, we'll come back to looking at dressings and that kind of thing. But if we're preparing for transfer, then we have to start to think about the burns really that David alluded to at the beginning. What is it that we need to do for the big burns to make sure that we give them the best opportunity of doing the best they can and having therefore the best outcome? So we have to consider in a very simple ABC way, airway, breathing, circulation. I'm a plastic surgeon. I'm very focused on the quality of the scar and the outcome of the wound healing. But you don't even begin to think about that unless we've got an airway, unless our patient's breathing, unless there's a circulation. So we have to consider airway, breathing, circulation. Does the patient need intubation? Is that something that can be done in that environment? If not, I suggest you sit the patient up until you see that the patient can get into a situation where they can be intubated, because if you lay them down flat, they will swell and they will lose their airway a lot sooner than if they're sitting up. So simple measures are important while you put in your transfer plan. Then we've got to think about the burn wound. We already have a question with respect to this. In our environment, we have to think about keeping the burn wound protected, and we have to think about infection control. We say cut clean sheets, glad wrap, for short periods of time. If the transfer times become extended, the infection risk rises, and therefore we have to move to silver-based preparations. And the SSD cream is the commonest one available, and that's the one that is most easily accessible, therefore easy to use. But it's not a question of putting on fancy dressings, it's a question of really protecting that wound and therefore the patient from an infection control point of view until transfer is undertaken, and then the patients can be reassessed at the base. Pain relief is really important. I think there is no substitute for intravenous analgesia. Each year we have a number of cases that will come through our hands where they've had an intramuscular injection of narcotic. They've then been resuscitated from a fluid perspective, and subsequently that fluid resuscitation has become effective. It has washed out the narcotic from the muscle, and then they have required Narcan to reverse the effect of that narcotic because they're then in respiratory difficulties. The intramuscular narcotic in burns is inappropriate. We have to look at intravenous. Of course, if you have the availability for intranasal, which some of the ambulances do carry now, and certainly in Western Australia, intranasal sprays, they're very useful. But by and large, IV narcotic is the way to go. And then you've got to think about the gut, the nasogastric tube, getting access to the gut for feeding as early as possible, but also for decompression. So those are the things that we really think about when we start to look at transfer. There's an awful lot there, and very quickly, so we can come back and discuss that as appropriate. But then we've got to think about what is it that we're trying to achieve? What is the purpose of this resuscitation, the feeding, the oxygenation of our patient? And the purpose of it all is wound salvage. The purpose of it is to reduce the impact of that burn injury. And we know that there is an area of the burn that will be necrotic, that will be dead, regardless. We will not be able to salvage that tissue. But we also know that if we have a patient resuscitated excessively, they will swell. And therefore the oxygen delivery to the area around the wound, the zone of stasis, will extend. And so essentially the wound will extend. We know that if we are inadequate in our resuscitation, then the oxygen supply and the nutrition supply to that wound, that zone of stasis, will be inadequate, and the zone of stasis will extend. So it's really a balance to ensure that we have appropriate resuscitation, nutrition and oxygenation, that we will minimise the impact of injury and optimise the outcome by limiting the zone of stasis. So we want to reduce that zone of stasis so that we have a situation where the scar that is worn for life is the least possible scar. So then we come to the crux of the matter is, who needs this burns education? And I think every intervention influences a scar worn for life. And therefore, everybody who really becomes involved and assists in the management of that patient is part of the burn team. So every one of you out there, as part of the burns team, as you are in the position of assessing that major burn injury, of putting in the drips, the oxygen mask on, putting in the nasogastric tube, you're now part of the burns team. And the communication link is vital. The phone call, then the maintenance of that communication link with faxes and pictures over the internet, whether we need to do escharotomies or not, that kind of thing is vital. So I think in order to deliver the best quality outcome in a remote and rural setting, it hinges on communication. And so I think really everybody needs burns education, as I've said, because unless they run away too quick, we'll nail their feet down and we'll tell everybody, from school children all the way through. And I think mothers groups is a very important group that we've highlighted as well already this evening. Very important groups. The elderly, whether they're in the bowling group or whatever, to go and teach first aid in that environment. Again, opportunities for education are vital, and I think that it's up to us all to educate those around us so that we can minimise the injuries. So now, I think, as I've said, we had a question on dressings, and Michelle, I'd like to ask you, we do lots of different dressings for our burns, but you see the impact of that dressing on function.
Absolutely.
So I'd like to ask you, what is your favourite dressing that you see put on a burn?
A favourite dressing for me is definitely a dressing that allows movement. And obviously if it's on hands, I don't want to see dressings with copious wrapping around the fingers which restrict the fine movements of the hand. If it's a dressing on an elbow, I don't want to have excessive secondary dressings that stop the full extension and flexion of an arm. So for me, it's really about minimising the secondary dressings and having a dressing that's actually comfortable for the patient to be able to move. That would be my favourite in terms of, obviously, a therapist.
And how do we facilitate that? David, what would you use in your practice as the first line burns dressing?
I hesitate to say this, but our practice still uses SSD in the main. Mm-hmm. I'm sure we could have quite a debate about SSD in terms of how often, for how long, and all the rest of it. But for an uncomplicated small burn, that's what we would use. Mm-hmm.
Well, I think there's a lot to be said for that, because it's safe, it's well tested, and it's been tried over 30 years, I think, now. I think one of the issues that has been sort of increasingly comes to the surface is the impact of silver on the rate of healing. And certainly in my early days, we would use SSD on donor sites, but we wouldn't use that now, because we know that impacts on the rate of epithelialization. So we tend to go for very simple things, something like a fixamol or a hyperfix directly on the wound, or with something like an alginate underneath it. And the fixamol has to be put on in the right direction to facilitate the movement. If you put it on in the wrong direction, then you're working against it. So the stretch is important. What about you, Eric? What's your favourite dressing?
Well, I'd like to reiterate the points that both of you make. I think if you make an assessment that a burn is going to heal within 10 days, then I would prefer not to use SSD on that dressing, as a dressing for that wound. I think if you have a wound that is a deep wound, that is a wound that is likely to have microbial contamination, a wound that's likely to require surgery, I still think SSD is a very good dressing for that wound. So because I deal with children, we like to minimise the number of dressings that we use. So the dressings that I like to use are ones that I can just leave intact, untouched until the wound is healed. So we would use either a dressing called Omiderm, which is a cellophane type dressing, but an alginate is just as useful. And some people even use the cheese type dressings that they use for colostomy bags, like Duoderm or something like that. Something you can put in place, leave intact until the wound heals from below.
I think that's interesting that we've bandied around a lot of names, and Marissa Pillar has sent in a question here and asked you which is the best: hydrogel, hydrocolloid, hydroactive, silicone-based, paraffin gauze, SSD, polyurethane foam, Codeabsorb, or those with growth factors. And that, I think, really underpins the question, underpins the problems that we have. There is a huge number of burns dressings out there, or wound dressings. So how do we know that we're choosing the best one? And I think people get very focused and say, well, this is the best way. And I think it sort of reminds me of a long time back when I was doing general surgery, and there was all the registrars arguing about which is the best way to do a bowel anastomosis. And I said, there's only one good way to do a bowel anastomosis, and everybody turned on me, and I said, one that doesn't leak. Yeah, and so I think there's only one good dressing, it's the one that heals the wound. And so really what you need to think about is, what does your wound need? If it's a very moist wound that is exudating, you need something that will absorb. And then if it's something that's dry, you may need something like a Duoderm, the hydrocolloid, that will keep it soft and moist so you can move. Because the bottom line is your dressing has to be comfortable. It has to have minimum dressing changes so that you reduce the psychological disturbance, because I'm sure, I'll ask David in a moment, that one of the biggest problems that we have is the anticipation of dressing changes and the pain associated. So you have the pain, the movement, and then the healing. So I'm not sure if you've asked specifically, David, about which time is the worst time in the burns unit from a psychological point of view, but have you a view on that?
Look, I think much of the time in there is very difficult for patients. But certainly the anticipation of going off to the what I used to see was the burns bath to get things removed was very traumatic for people, getting the dressings. And then I think the other part is when people were beginning to mobilise, especially when very extensive burns were involved. And it was very distressing, not only for the patients but also for the staff, because of the degree of discomfort for people.
I think that brings me to the next point, in that proactive analgesia really is important. And even if it's a small burn and you use Tramadol, now before the burn dressing gets changed, you will make a friend. If you pull that dressing off and give them the Tramadol afterwards, you will not make a friend. Yeah, I mean, and that's, you've got to think about, even in small wounds, the fact that you can give a Panadol, give the child pain stop an hour or so before they come. I mean, that makes a difference. It's just being thoughtful on those things. I'd like us now to think about a case. We've got Marion, a 42-year-old lady, who presents to your rooms with approximately about 2 hours after spilling hot cooking oil onto her anterior thighs. She lives on a cattle station approximately 35 k's out of town. She has 3 kids, 7, 10 and 14. Her husband at the time he was away droving, so she's there alone with the children. And before arriving, she's flooded the injured area with cold water for about 15 minutes. So she's obviously been to a first aid course. And then her 14-year-old son has driven her to see you. Now, we need to think about, we were looking at the missed mnemonic. the mechanism, the injury, the signs and the treatment. But how would you approach this? I'd like to ask David, first of all, David on the far left, how you would approach this.
First of all, I'd check the son's driving.
Yes.
Then I'd make sure that the patient was stable. You need a vital signs assessment. I would be keeping in the back of my mind that it's hot oil and thinking about the temperatures. I'd be thinking about analgesia and probably at the same time as assessing the burn, I'd be trying to get a drip in, or getting a drip in, and giving an intravenous narcotic. I would be wanting to look at the burn. I'd be wanting to classify its depth. I'd be wanting to know whether that hot oil had gone to other places, which might, other sites, which might influence my management. That would be my general approach as I walked up to the bed.
Thank you very much. How about Eric?
Yeah, I'm not sure that I can add too much to that. We've seen some very nasty burns from oil, and I think that's because oil is at a much higher temperature than for instance, boiling water. It can be 300 or 400 degrees. So my immediate thoughts are that this is, from history alone, likely to be a deep burn. There may also be splashes in different areas that we might not be aware of, and I could imagine that with the pain concentrated in the lap, you might not notice other areas. So I'd want to make sure that was all looked at. I'd be concerned about the perineum and whether any of the oil had dribbled between the legs and caused injuries in those areas, which may have a significant impact later on. So I'd be wanting to get her completely undressed and to make a thorough inspection and make sure that wasn't the case.
I think it's interesting, the body site. You'd have to be considering catheterisation, wouldn't you? We've got the fact that we've got the mechanism. We know it's hot oil, so our warning bells are ringing. We've got the injury site, and we know it's going to be a little bit deeper than a standard scald. We've got her systemic vital signs. I think I have actually, and her pulse rate is 120, blood pressure 140/90, temperature 36.9, and her oxygen sats 98%, respirates 18. And her airway is patent clear. So there's no surprises there.
No, it's good to reiterate that a burn is a trauma, and I think we should go through the ABC there, whereas the airway and the breathing look to be nicely under control. Her pulse rate's elevated. With an 8% burn, you wouldn't suspect that she would have lost a significant amount of fluid from that, but we don't know. She may have been dehydrated before the injury occurred. She's been cooking in a hot kitchen, and there's been a delay in time. She probably hasn't drunk anything in the meantime. She may have a significant amount of pain, so I agree with David that early aggressive intervention with intravenous narcotic will be very, very useful for her.
What would be a comfortable dressing for the perineum and anterior medial thighs? Because that's a challenge, isn't it? Because we've got to keep it there.
Actually, a technique that we've used on many occasions is the good old bike pants. Not going for a set that are too tight, but really getting an old pair of, or just a new pair of bike pants that are not too old, and actually using that as the basis to hold on the dressings.
That's a really good idea, isn't it? Because we're not looking at bike pants for pressure.
Nope.
Looking at bike pants because it's a hell of a position to dress. What would you put on to facilitate movement? What kind of dressing? I think this is a great case for SSD and a non-stick dressing, because your infection rates are going to be high because it's perineal. You don't want to have something with an adhesive because it will pull and tear and be awkward to move. So we often use an SSD nappy, like with you cut the incontinence pads, make a nappy, and then put the bike pants on. But the impact on the family, David, in the middle.
Yeah, look, this is a very significant thing in terms of this is a family that live in a fairly isolated area. A husband who's out working in the paddocks or out long way from the house, and there's a potential here in the long term of altering the dynamics in the family, what's expected of them, and so the woman herself may be affected emotionally because she feels less worthwhile in terms of what she's doing. We also need to think about in the immediate phase, she's going to be distressed, the son's going to be distressed, and the husband may even feel guilty about not being at home. And so there are a lot of pressures that are going on there. And this is a family that needs to be watched over a period of time. Again, one would expect that recovery for most people, but given if we do have burns into the perineum, that may also impact on the marital relation in the long term, if there are some long-term impacts from the burns.
Yeah, absolutely. Thank you very much. It's interesting that we also have another question here. Not the same kind of burn, but an unusual burn. A lady who is actually 8 months pregnant is a candle maker and was covered in hot wax. I'm not sure what surface area was involved, but the question we have is how best to remove that wax. Eric, any thoughts on that?
We had a situation just last week at the Children's Hospital with just this kind of problem, and with burns being a continuous re-trauma, we were very worried about the pain that might be associated with that. So we elected to actually do a general anaesthetic for the first dressing and to bride the wound under general anaesthetic for that child, which is unusual for us to do, but in that situation, that's how we dealt with that problem.
This lady is 8 months pregnant. Complicates things a bit, doesn't it?
Sure does.
I think it's very interesting because, again, it's one of these situations that there's no right answer. Everybody's unique. Every burn injury is unique. And in answer to this, we've got two choices: to remove it or to leave it. To remove it involves pain. I have a lady who came to me not long ago because she was told to scrape it off with a sharp knife. I think she was very brave, really. She achieved it, but it was significantly traumatic. And interestingly, she went on to have a prolonged pain problem, even though she had a relatively early healing solution. So I would, in this circumstance, with somebody who's pregnant, and I think the surgical option is very good, because then you're in control. With somebody under general anaesthetic, spoken, I suppose, like a true surgeon at the end of the panel, you're in control, you can deal with it, and you can make sure that you get a really good quality first dressing and you've removed all the debris. In this circumstance, I would go for leaving it intact and cooling it. Really cooling it, because once you've got the heat out of the situation, you've then in fact sealed the wound. And what is wax as a dressing? And I would treat this patient like you treat bitumen. And with bitumen burns, you don't try and take it off, you wait till it because it loses its heat really quickly, and underneath, the vast majority of those burns are partial thickness and will heal without any problem at all. So you cool it very aggressively and maintain that cooling for a prolonged period of time, and then it shells off like a cocoon. That would be my solution to this one. So thank you very much for that question. Right, I think I'd like to now ask Eric to go through some more of the management essentials, if you could please, Eric.
Thank you, Fiona. What we're going to try and do now is have a look at assessing the wound with respect to the depth of the burn. I'm going to try and have a look at classification and what the nomenclature is, what the characteristics are of the particular depths of the burn, a little bit more about dressings and theories behind which particular dressings you might choose in which situations, and then again to reiterate what the referral criteria are for patients who might need to come to a burn centre. So with respect to the nomenclature, we split up burns into 4 different depths. The first depth is the epidermal burn, and that's what we see when there's a sunburn. There's no loss of the epithelium, it's all intact, it's a dry surface. They can blister, but usually not on the first day, usually on the second day or a little bit further down the track. The next wound we classify as superficial partial thickness, and then also the next layer is a deep partial thickness. Now both of these burn wounds are into the dermis of the skin to a differing degree, and we'll talk more about the differentiation between them in a moment. The final classification is the simple deep classification, or what we would call a full thickness burn, and that's when all of the elements of the skin have been destroyed. So let's have a look at a schematic sort of representation of the skin and see if we can have a look at where those depths lie. If you have a look at the sort of cross-hatched section at the top, that's the epidermis of the epidermal burn. We then split up the dermal burn into superficial partial thickness and deep partial thickness. And you can see there's a dotted line that runs sort of through the dermis there. Now that's an artificial dotted line, and it's a dotted line that we never actually know where it is. But above that line, the wound is going to heal spontaneously without the need for any surgery. And below that line, the wound is deeper and will have a better final cosmetic and functional result with a debridement and a split skin graft. Now, historically, only time would tell us what that was, but we can differentiate between superficial partial thickness and deep partial thickness with the passage of time and with some things that we can look at. So let's have a look at the outcomes and the different treatment of those different burn depths. If a burn is going to heal within 10 days, if that's our prediction, then we can treat that burn conservatively and dress that, as we've already discussed. The difficult area are the burns that are going to heal within between 10 days and 3 weeks. They're the ones that are more likely to be deep partial thickness burns, and they're the ones where we have the difficult decision-making process. In children, that's the majority of our burns in the scald population, and that causes most of our sort of heartache in the hospital. There are some burns that are obviously deep and obviously full thickness. They're burns that would either take more than 3 weeks to heal or even longer. It's quite clear that those burns need to go straight to debridement and split skin graft. So that decision-making process for those is quite easy. Now let's look at a couple of examples of those burns and see if we can differentiate between them. So the first one we want to look at is a superficial partial thickness burn. This is a burn that is salmon pink in colour. It's moist. There may be some blisters, some may be intact and some may no longer be intact. In this little girl, you can see that the blisters have all disappeared. They've all sort of come off the skin. With a sterile sort of finger inside a glove, if you actually press on that, you'll find that there's good capillary return and it blanches. It's also the kind of burn that even exposure to the air is painful. The nerve endings are very right at the surface, and these kids don't like being exposed at all. And these can be very, very painful burns.
That's a classic site as well, isn't it, Eric? That site, the chin and the front of the chest.
It's the spill scald.
Yes,
yeah.
that would be the commonest pattern of injury that we see in paediatrics.
I can almost see it happening, reaching up to the counter to grab that cup of coffee which is above you and pulling it down. Let's have a look at the differences now between superficial partial thickness and deep partial thickness and see if we can differentiate between them. Here's an example of a classical deep partial thickness wound with almost some elements of deeper. You can see that it's got a cherry red appearance rather than the salmon pink appearance. It can be mottled. If you actually press on this with the glove, you'll find that there's sluggish or no capillary return in this. Even though it looks quite red, it looks like it's got a good vascularity, but that's actually hemoglobin molecules that have left the circulation and that are trapped in the dead tissue. It is said that these burns have less in the way of pain and more in the way of discomfort. I think this is probably not a good differentiator in that all of these burns are painful and that all of these burns have elements of different thicknesses, so not a good differentiator. But they don't tend to have that same sort of exposure tingling pain that the superficial partial thickness burns have. And the final example here we have is of a deep burn. Here you can see a classical deep burn. It has a white leathery appearance. A deep burn may also be charred or have sort of blackened elements. It's leathery and firm to touch. It's dry. There's no blanching when you push on it. The centre of this burn is going to be insensate, so you can actually put a needle into that and the patient won't feel that at all. Again, I want to reiterate that that doesn't mean that this burn isn't painful, because you can see a large amount of deep partial thickness around the rim and even some superficial partial thickness. So there's actually quite a significant surface area there that will be painful for him. Just to reiterate that point that there are many different aspects and depths in each particular patient, I just give you this last example of a boy who has practically every example of a burn in demonstration here. There's the salmon pink of the superficial partial thickness, the deep cherry red of the deep partial thickness, and then the whiter patches. I think this is also a salient point about the pain of a burn. You can see that this boy's obviously in terrible distress.
We've just had a question come through, Eric, which I think with that image would be quite useful. How do we assess the percentage body surface area, and in particular with electrical burn? So looking at that young fellow there, what percentage body surface area would you assess that to be involved in that image?
Well, a good rapid method is the rule of nines that we use, where the entire front half of the torso will be 18% and there'll be 9% on each arm. So I would just estimate there that probably a little bit more than half of the anterior torso is burnt, so that's probably worth about 10%. I'd estimate maybe 5% on each arm, and then maybe 3% down the thigh. So it's getting up to, what, 23, 25%, just as a rapid estimation.
Thank you very much. If, again, answering the question that's just come through, how would we alter that percentage assessment in an electrical injury?
Electrical injuries are very difficult because what you see on the surface might not be the full extent of the damaged tissue, and they can be very different. They're very dangerous. There can be muscle necrosis up an arm, for instance, and the external injury is just a small entry site. So the estimation of the body surface area in an electrical injury can underestimate the significance of the injury. And I think it's one of the reasons why it's a very strong referral criteria to a tertiary burn referral centre.
I think that's the bottom line, isn't it? Electricity, warning bell, help. Talk to somebody who's used to seeing it. Absolutely. Sorry, Eric, do carry on.
Yep. So we've talked about how we can predict a burn wound, and we've talked about why those predictions are important in working out how to treat a burn wound. A wound that's going to heal within 10 days is better left with dressings. A burn that's not going to heal is better with early surgery with debridement and split skin grafting. It's that middle range, it's the ones where we're not exactly sure what's going to happen that are tricky. We've been trying to help ourselves here with doing some laser Doppler studies on our burns, and this is where we shine a laser light on the burn, and we do this on either day 1 or day 2. And the theory behind it is that if the laser frequency is altered as it returns back to our monitor, the so-called Doppler effect is in place, that suggests there's some movement in the wound bed, that suggests that there's some blood flow and it has the ability to regenerate. So if you can see this example here, you can see this is a burn on the shoulder and back of a little girl. The area that lights up bright red, that has a huge change in the frequency, and that suggests a lot of flow in the bed, and that's an area that we can confidently say will heal spontaneously in that sort of 10 to 14 day period. The patch under the scapula, though, is different. It has a lower frequency change, and some of the areas are blue, which is no frequency change. They're areas we can confidently predict are deep and will require early surgery. So that's been helping us a great deal. A lot of people say that would be helpful to predict who you can operate on, but we've actually found that it's better to predict the ones who you don't have to operate on, because they can have a dressing plan put in place and can be sent back to the country or to their home with that plan, and we can be confident that they're not going to require surgery. So that's been very helpful in that intermediate group, and I have to say that our study only involves children. So when we've decided what we think the depth of a burn wound is, then we can start deciding what kind of dressings are needed and what kind of referrals are indicated, if at all. The historical mainstays of dressings we've talked about are SSD and also Vaseline impregnated gauze. And I just brought an example. Everyone knows these Vaseline impregnated gauzes. They're available in every accident and emergency in the country. This particular one is called Bactigras, and it's impregnated with chlorhexidine, so it has some antimicrobial action. It's a very, very good dressing for burn wounds. One of the negatives of it is that it does need to be changed probably daily. You may get away with second daily, so in that respect it's not as good as a dressing that can be left for longer. One of the other dressings that we use, and this is probably the dressing we use the most commonly, is a silver impregnated dressing. And the way that I would summarise this is slow release SSD.
Absolutely.
I think that's basically what it is. SSD has a half-life of maybe 6 hours, and so its action is significantly less at the end of a 24-hour period, whereas this continues to deliver silver to the wound over a 3-day period, and there's even a preparation where it does that for 7 days. This is the dressing that we use most of all. I've actually got a picture there of a sort of a cut-through of that dressing. You can see it's just a simple polyester core and then a polyethylene mesh on the top with what's called a nanocrystalline silver impregnated into it. And that will give really good antimicrobial action over a prolonged period.
I think that's one of the issues with this is it's the cost, isn't it? And who do we need to use this for? And certainly it's taken place of the SSD in our tertiary referral burns units, and it's the most common dressing used in every state centre, I know. Whereas, do we use that in the rural environment? And that's really a tricky question, because if you really look at needing that level of infection control, do you really need to think about referring the patient? So I think that when you get to that, sort of considering that you've gone beyond SSD and you're looking at Acticoat, then I think you're looking at referral. Would that be fair?
Yes, I think so. I think it suggests that the burn wound depth is of a depth that is likely to require surgery, or is on the cusp of likely to require surgery, and will require dressings for a prolonged period of time. So yeah. I'll just move on. I'd just like again to summarise just a couple of points on the referral criteria, because I think that's very, very important, because what we know is most burn wounds are not coming to our centres, and the vast majority of times that's entirely appropriate. But there are some situations where we'd very much like early communication and early referral. We've already talked about the body surface areas of 10% body surface area and 5% deep. I'd just like to make a specific mention about inhalational injury, though, and I'd like to include even the suspicion of an inhalational injury. Any sort of burn injury that occurs in an enclosed space, a car accident, the 14-year-old who's trying to blow up the back shed, is another classic, where there may be inhaled products of congestion, where the temperature around the victim may have been hot. And I think that's very, very important, that the suspicion of inhalational injury means immediate communication and almost certainly transfer. I've got an example of a boy who was playing with the fluid that powers aeroplanes, toy aeroplanes, and this is a photo that I took 6 hours after he presented to the hospital, and I think it would probably be impossible to intubate him at this point in time, whereas when he presented to us at 45 minutes he was actually talking, and the anaesthetist was able to do almost like an elective nasal intubation with no problem and secure the airway. So I think that's a very important point. We've already talked about electrical burns and their importance. Chemical burns can also be very tricky, especially ones that may have splashed in the eyes or the face. Fiona's already talked about circumferential burns and how that the constricting eschar can stop the blood supply to the distal limb. A circumferential burn can also have airway implications if it's around the abdomen or the chest and can restrict breathing. If you remember the picture of the deep partial thickness burn wound of the hand that I showed you earlier, this is after a release of the eschar has been done, and you can see how much pressure was in that hand, and that was done because there was actual distal ischemia of the fingertips, which then it returned after these escharotomies were performed. So circumferential burns are very important. Burns of special areas Fiona's already discussed, and also the extremes of age. I think any burn in a child sort of less than 5 we would prefer to look at and look after in the burn unit, and also the elderly with their comorbidities are very complicated in some instances.
Thank you very much. I think that's one of the point you make at the very end there is the extremes of age. And extremes of age are also very vulnerable. And non-accidental injury is something that we have to be aware of. And we have also become increasingly aware of in the elderly. I mean, it's certainly topical currently. David, have you come across any such problems? The complicated family dynamics certainly do impact on the incidence of trauma, as we've said, but also the recovery.
Fiona, unfortunately, we do see a number of these where children have been deliberately burnt by family members, either because of neglect in a sense, but also because people have actually put them in water, and so there are problems there. But you also may see this in the elderly, where they come in with cigarette burns placed upon them by angry children who have been living at home with them. So, and unfortunately, it is an increasing problem in our community.
Have you seen the change in incidence with respect to non-accidental injury and domestic incidents and violence?
Yes, in part. I was thinking more particularly in residential care, we often find, well, no, not often, but often enough, find that elderly folk are burned, and really there need to be some hazard identification protocols in place in residential care for older people so that doesn't happen.
I think that's a very interesting point you make. The concept of a cup of hot drink warmed in a microwave and a little bit hot on the handle, it's straight in the lap. And then it's straight through full thickness because it's microwave, it's hotter, it retains heat more. So that sort of is a relatively simple thing to stop, isn't it? Yet it's something we see frequently. And so that's an accident, of course, but I think that it's the hazard identification. That's the real key, isn't it? Looking to see the problems before they occur. Yes. One of the questions we've been asked that, again, has come through, so thank you very much for keeping the questions coming, is do we leave the blisters intact or debride them? This is always asked, and I'll give you my answer first. Take them off. Because your dressing system will be more effective if you've removed the blisters. I will make one caveat that if you remove blisters on the palms of the hands or the soles of the feet within 24 hours, you will lose a friend, because it's much more painful. So we tend to do that over a 24, 48-hour period. But otherwise, I would remove the blisters so that the dressing systems are effective, no slippage, therefore they are less uncomfortable. But that's just the philosophy I follow. Eric, what about you?
Yeah, I agree with you. We have a policy of removing the blisters, but we don't tend to do it immediately upon admission. We tend to admit the patient to the hospital, and then I think the most important thing is to get them both settled into the environment from a pain perspective and from a comfort perspective, and then in a more planned setting, then we make sure their analgesia is right up to scratch, and then we would do a so-called burns bath and debride the wound and remove the blisters. And that would classically be at about somewhere between 18 to 36 hours after admission.
How about you, David, in the small burns that you see coming through your rooms? Would you, if there's the blister there, would you just leave it, or would you split it, debride it?
Aspirate it.
Aspirate it.
That's what I do, but I hear you, and again, this might be very useful for the viewers out there. I think that you're suggesting that the dressing system will work better if you de-roof the blister.
Yes, and if it's too difficult and too uncomfortable to de-roof, then to split it, to actually snip the surface off rather than aspirate, so it's really well and truly decompressed, then you get less shift. What about function with blisters?
Well, I think obviously if you've got a lot of fluid in the actual wound, then you'll need to actually lance the blister and actually remove the fluid, and I think that's obviously a big consideration as well. But I think the other point is that in terms of making sure that you've actually assessed the depth of the burn, and the only way to do that is actually either to remove the skin or to make a section so you can actually correctly assess the depth of the burn.
Absolutely, good point, Michelle. And I think that brings us to a very important point this evening, that this is a team approach. It's a multidisciplinary team approach, and I'd like to ask Michelle to explain why.
Thank you, Fiona. Look, the rehabilitation of a burn injury really does involve a big team, and if you're admitted to a burns unit, you'll actually be seen by the full facet, and that'll cover issues such as the physical side, the occupational functional activities, psychosocial, social, nutritional, communication and swelling, and you'll be seen by a facet of health professionals from physios, OTs, psychologists, social workers, psychiatrists, dietitians and nutritionists. Now obviously if you have a big burn you've got lots and lots of issues, but I suppose what I wanted to focus on today is picking up a few key points that you might actually, when you're treating somebody locally, need to think a little bit further than just looking at the wound care, but when you might need to actually refer to another health professional. So in terms of a physio and occupational therapy, some of the key points where I'd like to highlight the need for involvement is if you actually have a patient who is going to be grafted or healing time of greater than 14 days. As we've already talked today, these are the burns that are more likely to scar. Also burns that are over joints, or if you're already seeing poor movement in the very early phases of the burn, then it's time to look at referral, if able, to a physio or an occupational therapist. And again, paediatric burns are not as likely that you're going to be able to tell a paediatric or a child, start moving your hand or start moving your limbs, so you'll need some more special attention to these areas. On top of that, the occupational therapist can play a key role in looking at the difficulty in managing your daily activities and lots of the difficulties with return to work and school after burn trauma. Now when in looking at the social support, again, whether it be a social worker, a psychologist or a psychiatrist is involved, I spoke to my colleagues about what are some of the key things that they would want picked out. And they actually said previous psychosocial issues, including maybe Department of Community Service involvement, domestic violence or a lack of family support. They might be, if they're already showing current adjustment to injury issues, if there's workplace or school integration issues. And again, my colleagues at the Westmead Kids Hospital have actually said, look, the majority of paediatric burns should all be referred to for social support, just because of the multitude of complex issues involved in their care. Speech pathologists, look, with a minor burn that doesn't meet the criteria for transfer to a burns unit, the key things that you'd be looking at is the intubated for greater than 48 hours, if they've undergone a tracheostomy, or if they've got swallowing communication issues. Obviously the speech pathologist's role is a lot more diverse than that, including facial burns, but again we'd like to have hoped that they would have been transferred to a primary care facility. On a nutritional side of things, we'd be looking at your unstable blood sugars. So again, if you've got somebody with diabetes, you're going to have more troubles with healing. So early referral to a dietitian. Previous nutritional issues, and my colleagues in the kids hospital again say poor oral intake with a child or issues with vomiting and diarrhoea should have early referral. So as my role as an occupational therapist, I suppose I have a very big role in scar management. So looking at, with burns, what burns are actually going to scar? Well, we have a number of risk factors that we've already talked about. Children are more likely to scar. Even a minor burn that heals in 10 to 14 days with risk factors of dark pigmentation or a genetic predisposition are more likely to scar, as well as the length of time to healing and patients that are actually grafted. So what is a scar? Scars are not just cosmetically unappealing, but they can have a big range on actually movement. So a scar is actually healing or overdrive. Although it may start off looking initially soft and pale and pink, what you can find is over a period of 2 to 4 weeks, you'll actually get increasing vascularity. I think the importance as a professional then, or even as a GP nurse looking after these burns, is actually to monitor these wounds. So although you might have seen lovely healing at 3 weeks and you think, fabulous, that patient is not necessarily out of the woods. So again, look at going 3 weeks, maybe I need to make a referral or get this patient back in 2 to 3 weeks' time to reassess and look at whether there's any need for ongoing scar management. Again, poor scarring leads to terrible functional outcomes, terrible contractures that affect not just the functional side of things but the physical and psychological things. So again, with a child, for example, in the hand that's showing here, these burns might have healed in as little as 3-4 weeks, and again, terrible results for that patient's functional recovery. Again, contractures don't start straight away, so making sure early referrals and encouraging this person to move will make a big difference to their outcome. Now, I suppose anybody that's working with a burn injury takes care in terms of how they're going to manage this burn. We rely as therapists very much on the involvement of doctors and nurses because they're the ones at the front line of the care of a burn in the community. And I think there's some very key points that they'll be able to give to this patient to maximise their outcome as well. What I'd like to encourage is that with any burn that heals in under 14 days, that you should have early unrestricted movement of all affected joints. Early movement encourages muscle pump, which decreases edema formation. Don't give a patient with leg burns a walking aids. Encourage them to walk. Even if it's poor walking patterns at first, this person then will eventually walk and not develop dependency. Encourage functional use of the uninvolved limbs and make sure that the person knows, look, you've got a burn to your arm, but it's important that you actually do feed yourself, start to involve yourself in your hygiene, and don't be weighted on hand and foot. And that's really important in terms of communication to the caregivers as well.
It's much more important to give good pain relief and allow them to walk than to give them a Zimmer frame.
That's right.
Absolutely.
Absolutely. I think the other things that we need to be aware of is even once the burn wound is healed, even if it's a minor burn, it's important to look at sun protection and moisturising. If we go and allow a newly healed burn wound to go and get sun exposed to it, you can affect the long-term pigmentation of the burn, you can cause further skin damage, and you can also develop skin cancer at a heightened risk. Again, you'll have effect to your sebaceous glands at first, so again, additional moisturising. You should be considering splinting and positioning, especially in the children, even for minor burns under 14 days. And positioning for edema management, encourage limbs to be elevated, not necessarily thrown into slings, because slings can again discourage movement around surrounding joints, but encourage elevation in the early stages of a wound. Now, in terms of deeper and grafted burns, there are going to be a lot of burns that are actually managed out in the community that may be actually even grafted or have delayed their healing. So in burns that do take longer or grafted, it's really important that these actually are referred and assessed for scar management. And scar management may consist of compression garments or even compression bandages. There's also silicone gel, which is very well known and used very widely in burns treatment for the softening and flattening of scars. And also getting into a very strict stretching program, because as this scar heals and develops scar tissue, it will shrink and contract, so we need to be providing stretches in the opposite direction. Again, early movement is really important in the deeper burns. So commence physiotherapy or occupational therapy, provide lots of stretches, splinting against the line of contracture, positioning, and formal edema management. And I've got some photos to show some of the issues that we'd be looking at here. We've got a gentleman that's actually mobilising. Again, this is a patient that's in a burns unit with 40 to 50% burns, and he is walking, all lines attached, all tubes intact, and very, very important not to learn to start walking with walking aids. On the opposite side, you've got some formal compression garments. These are used to help flatten and soften the developing scar tissue and can be used in conjunction with silicone gel underneath the pressure garments. And if we go on further, looking at edema management as well. So if you've got edema in limbs, look at options such as cohesive wrap, tubey grip, as an early frontline edema management. And even on the bottom shot, you can actually see that you've got really just a graft on a trunk that's actually causing tightness in all the surrounding joints. So very important to do early movement and stretches. And so what are we actually aiming for in our burns? We will, if we do the correct treatment, and sometimes this is hard in hindsight, but we'd like to get a cosmetically pleasing result. We'd like to have full movement, full function. Sometimes, like in the example of the trunk burn, we will actually have some dimpling, but again, we've got a soft and flexible skin. If we go on further, we'll actually see that we're actually trying to look and making sure that that person has got full range of motion and full function. Although that scar has further to go in terms of fading, it will be a cosmetically pleasing result with full range of motion and will help that person to adapt to their normal life. So really, I suppose that's the important key, is that we've all got a role to play in terms of improving the movement of a patient and their scar outcomes, and it's very much a team response as well. So
I think that's very important, isn't it? Thanks for that's early. Keep moving, normalisation of everything. I think that is very important. We were taught historically to rest the injured part. What do you feel about that now, David?
Oh, I think it's important to keep moving for all types of reasons, and I'll be interested in David Crompton's advice to us about normalising patients as much as we can. But in terms of function, there's no substitute for early movement.
Absolutely.
And I think also very much the role of communication between team members as well, and how the nursing staff are a very key role in management of a burn, but they can be actually feeding information to the other health providers as well.
Absolutely. I think the nurses are pivotal, aren't they? They're the ones that spend the most time at the bedside, and that understanding of the pain that the patient's experiencing, the facilitating a dressing system that can allow therapy, and then feeding back to the psychology team where the people are more vulnerable, where they're dipping. I think certainly the nurses are a hub of all our work. I think we've seen some certainly significant scarring in some of the images there, David, and these injuries, we are all too often, as I said at the beginning, get overwhelmed with the physical, but there's the scar on the inside. Could you take us through some of your thoughts with respect to that?
Thanks, Fiona. Look, it's very interesting. As I was thinking of preparing this talk or discussion for tonight, I was reminded when I was actually working in one of the burns units in Queensland, and that often when I was asked to go and see somebody, is look, would I come up and see Mrs. Brown who has burns? And I think we need to be aware that the effect of trauma is more than just the trauma itself. We need to be cognizant of pre-trauma events in people's lives, such as other traumas that have happened to them, what the age of the person, and also what their past psychiatric history is. We need to remember whether we've got an event that's been man-made or it's happened due to things such as bushfires. Often man-made things may be much more catastrophic for people because there are other issues involved, such as litigation. There may be poor workplace safety issues involved in those people. We need to think about what was happening during the trauma, and also we need to be aware of what went on in people's lives after the burn occurred. As I was thinking about the impact of the injury on people, I've divided it up into thinking about the physical problems that people that occur in people, the social impact on their life, and then also the psychological and eventually the recovery things. When I think about the physical aspects, I think it's been mentioned about the loss of function. I think it's so important that we need to act on this quickly, because psychologically, if loss of function continues, it will have a detrimental effect on people's lives. The appearance is a very important part, particularly in young people and also women. The loss of appearance will have a significant psychological impact. In terms of the social aspects, we need to think in the long term of this loss of income. A person may lose their job or their role may change. There may be this impact, particularly in young people, on their educational gains, and that they may be time away from school. And then we also need to consider the impact on the family, friends and other community members and how they respond to the injury. Psychologically, there's this immediate impact, which may for some people be distress, for others it's going to be an anxiety. Then it moves on to a short-term gain or problems that people experience, such as a mild degree of depression, increased anxiety, and in the long term there may be major depression or a disorder known as post-traumatic stress disorder. When we think about the recovery, I think it's important that we've got to remember the role of the family and other carers. We need to engage employers when we're helping people to recover. We need engagement with the educational system, and again it's that community support role. And particularly in rural areas that's so important because often there are a lack of other resources and the community steps in and helps. Look, when we think about problems, the psychological problems related to burns, look, there are often a number of myths that go around in terms of trauma. We often think that everybody's going to panic. The reality is many people don't. They cope, and they cope very well. We're often told, look, don't give too much information to people. Again, that's one of those myths. We need to inform people what is happening. We need to give as much education as possible. There's already been a question tonight on the issue of children and its impact. Again, no child is too young to be affected. We need to be aware that the effect can be immediate, but also many years later people can develop problems. There is another thought that people have, that if they don't crack up, as some people say to me, at the time of the event, everything's going to be all right. The truth is, individuals that have been involved with burns or those who are around them may develop problems many years later. Again, one of those myths that people have mentioned to me is, look, people just never get over these things. The reality is people do get over, and they move forward, and many people become very actively involved. And certainly in my years in working in a burns unit, one of the key people involved in helping people recover was a person who'd been involved with burns in themselves, and that had significant burns but were now contributing to the community. And finally, I think we've got to remember those people who have been in the emergency care area, they also may be affected. Now, often in talks such as this, what I'm asked about is post-traumatic stress disorder. The reality again is that many people don't get this. They either have no change or they may grow. But we need to think about physical symptoms that people get, such as sleep disturbance or somatic complaints or an adjustment disorder. And these things may happen very early on, but they may represent a greater problem. Along the way, people may develop grief reactions because they may lose a part of their body in terms of its function, or actually a part of a limb. They also may develop other disorders such as mood disorders, and then also a small percentage, 10%, go on to develop post-traumatic stress disorder. Another question raised was really about personality. We need to remember that in the long term, some people move on to develop substance abuse because of loss of function, because of the ongoing pain they may experience, or other deformities. There's particularly in young people, a loss of self-esteem. And then we need to think about the impact on vocation and also the relationship. I mean, the woman in the case, if she's had perineal burns, may go on to develop sexual dysfunction, and there's going to be an impact on the relationship in the long term. If I want to summarise a way of helping people, a person described to me what's called the Hearts model. And the first thing we need to think about is making sure we listen to the history, and that's the history of the present, but also the past. We need to think about the emotions of the individual at the time, and that may be tied up in some of the symptoms that you need to ask about, such as pain, because people often forget about the pain and they don't treat it well. We need to give good explanation to people why things are occurring, what we're doing. There are very simple techniques that we can teach, such as relaxation and coping skills, and then we also need to move on and help them develop self-change. Now, finally, I think the other part is some people who go on to develop specific mental health disorders may need to have certain interventions, such as cognitive behaviour therapy or pharmacotherapy, and they're very specialised areas, and they need to be discussed with professionals involved in that.
Thank you very much indeed, David. I think the Hearts model there is a very useful one, and one that's very aptly named. I think I'd like to. It's been a fantastic opportunity to discuss lots of things tonight, burns is a massive area. It can be a minor thing that you get burnt with an iron and it's just a nuisance, or it can be a life-threatening problem. David, what questions have you have of us at this point in the evening, just before we wind up?
Well, not so much questions, because I think that we've covered a lot of ground. I think as a rural GP I would be looking for a copy of this video from the Rural Health Education Foundation, or reviewing it using webcasting techniques from our website, because this really is a presentation that the whole team needs to look at in terms of nursing, in terms of doctors, in terms of practice nurses. I think there's room to think about prevention. We've covered that, and I think again that there's a lot of useful things that doctors could do out there in their own right, and other health professionals, of course, together with divisions of general practice. There's lots of good things that I think could be done. I think the principles of management of a larger burn are always a problem for rural general practitioners, and particularly the special cases. I can remember the last inhalational burn that we had, and we couldn't emphasise too strongly to the nurses to actually get that patient to theatre so that we could perform an intubation, and that was the key to it all. I think the other key message from tonight is that if you're out there in the remote areas, that you need to develop a management plan for each burn. And maybe we don't look at burns quite that way. It's a day-to-day thing, which it is. We have to go back and review. That's been mentioned a number of times, to keep reviewing. But it's just having an overall perspective and management plan that not only draws together matters such as how it will heal or what dressing you put on it, but looking at all of the other things that matter, and particularly the psychological aspects of it. So I think they're the challenges. You don't hear a lot about burns education out there, and I think that this is all very useful.
Well, thank you very much indeed. I hope you've enjoyed tonight's programme on burn injury. If you're interested in obtaining more information about the issues raised in tonight's programme, there are a number of resources available on the Rural Health Education Foundation website at rhef.com.au. And don't forget to complete and send in your evaluation forms, and please register for CPD points by completing the attendance sheet. Finally, I'd like to thank the Department of Health and Ageing for making this programme possible, and thanks also to you for taking the time to listen and to contribute. And particularly I'd like to thank the panel for your stimulating discussion, your valuable input, and a great evening. Thank you very much indeed. So I'm Fiona Wood, and good night from me. Thanks.